rolling here. Gonna flip up the chat. So as you know, we're going to be talking about GLP-1s. We have a guest speaker, which we'll introduce in a minute. There is some housekeeping rules, just to keep everything smooth and respectful experience for everyone. Want to have respectful engagement, so please be respectful and considerate in your communications. We want to aim to create a positive and constructive environment. Chat guidelines, just for sake of time, the chat function is limited to only chatting with the host. So if you have any questions throughout the presentation, you can just please send them over, and then I can make sure we ask, there's no double up on questions. We will have time at the end for questions at the end of the presentation. If you have any technical difficulties, you can just go ahead and message me on the chat, or if you need to email me, I'll have that open as well. And then, of course, we are recording it for some people that couldn't make it, and we post that as well. So we want to keep everything. And please, I forgot to have your, you can have your cameras on or off, but be muted. Okay, pass it over to Natalie.
Okay, I will introduce Dr. Whitney Blakely. We are so excited to have her join us for our coalition meeting today. Dr. Blakely earned her medical degree at the Medical College of Wisconsin in Milwaukee. She completed a residency in internal medicine at Vanderbilt University Medical Center in Nashville. And she is board certified in internal medicine and obesity medicine and is currently a bariatrician and medical director of medical weight loss services for Community Health Network in Indy. And yeah, just wanted to say thank you for being here and speaking with us today.
Thanks for having me, Natalie. I did learn how to pronounce, oh no, now I'm going to butcher it, Kosciuszko?
Kosciuszko.
Kosciuszko. I was going to try so hard. Thank you all for having me. I am excited to speak with all of you. I know the focus today was on GLP-1 medication. So that's certainly what I want to spend the majority of the time talking about, and certainly taking some questions and utilizing my experience and kind of using these medicines on a day-to-day basis to talk about obesity care. Let me go ahead and try to share my screen here. Oh, is someone it's disabled right now for my screen.
Jessica, I just have that.
Okay, thanks. I have a PowerPoint here that I was going to start, if that's okay, if the time is okay.
Absolutely, yes. Sorry,
okay.
I should be good to go now.
Perfect. So I will I have some slides, bear with me. I did want to present a more complete kind of picture about obesity as a chronic condition, because I think when we talk about GLP-1s and all the attention that they're getting, we need to be critically aware of, coverage and the things that factor into coverage, and how both clinicians and patients alike are kind of using these medicines, and how the conversations are going regarding these medicines. So I will probably try to go over things pretty quickly and then slow down a little bit more when we get to the GLP-1 medicines themselves. I wasn't entirely sure if I was going to be speaking to people who were prescribing these medicines. So some of it might get a little bit kind of long-winded, and if that's the case, we'll just kind of speed through that as well. But thanks again for having me. My disclosures: I am a paid speaker on behalf of Lilly and Novo Nordisk. Our objectives today, or my objectives, are to identify obesity as a chronic relapsing disease that requires long-term management. I'm going to touch a little bit on weight bias and stigma, because that informs a lot of our discussion about weight and about treatment of obesity. And then review indications for the initiation of anti-obesity medications, which I will kind of refer to as AOMs, but that's what that stands for. And then, of course, we'll get into our GLP-1 receptor agonists as far as their mechanism of action, dosing, side effects, and contraindications. Kind of a touch on the future of anti-obesity medications, and then hopefully leave ample time for question and answers at the end. I always like to start with the definition of obesity from the OMA. I think this is a very challenging disease process with a lot of factors, but I think this definition does a pretty good job of kind of incorporating all of the issues. So they define obesity as a chronic, progressive, relapsing, and treatable multifactorial neurobehavioral disease, wherein an increase in body fat promotes adipose tissue dysfunction and abnormal fat mass physical forces, resulting in adverse metabolic, biomechanical, and psychosocial health consequences. So a long definition, but really
Whitney,
touches on,
One
yeah.
second. Are you supposed to be sharing slides?
Yes. Can you not
Okay.
see them?
No.
Oh, goodness. Okay.
Or am I correct in that anybody can see them? Okay.
I am sorry. I
That's
thought that they were being shared. Can
Now-
you see anything now?
Yes. Yes.
Okay. Sorry about that. Well, you
That's
didn't
right.
miss much, just my
Perfect.
objectives and my titles.
Yes.
So here we go. Okay. Thanks for letting me know. So prevalence, just to touch on prevalence and why this is something we should all care about. It is estimated that by 2030, 50% of Americans will have obesity. That's not a BMI greater than 25. That's a BMI greater than 30. And 25% of that cohort will have severe obesity, which is defined as a BMI or body mass index greater than 35. Currently, nearly 1 in 5 children also have obesity, which certainly the pediatric incidence of obesity is talked about often. Just so we can see specific to Indiana, our obesity prevalence, this was data from 2022. You can see Indiana is in the circles, pretty much always outpacing the national prevalence here. But if you can look, the start of this graph on the x-axis is 1990, going all the way up to 2021. We can see that just steadily increase over the years. Our, percentage of adults with obesity is hanging out around 36, 37% in this state, and obviously on the rise. Important, I think, to touch on briefly that obesity is a chronic disease. So it's a relatively new disease compared to a lot of other diseases that we treat clinically, but the signs, symptoms, and pathophysiology of obesity do fulfill the definition. It was defined as a disease back in 2013. We know it's a complex disease. It's related to genetic, epigenetic factors, environmental factors, sleep, reductions in smoking. Obviously, our society has changed a lot, in the past 50 to 70 years. So there's so many factors that inform kind of how we think about obesity and how we manage it. Obesity may result in cellular and organ anatomic and functional abnormalities. I'm going to kind of skim over the next few here. And then I bolded, excuse me. I think an important piece to highlight here is many diseases are promoted by unhealthful behavior, and obesity is no less of a disease when it is promoted by unhealthful behavior. So often, we'll talk a little bit about stigma and bias as we approach this disease as well, and some of the barriers to care. But we wouldn't not treat someone's lung cancer because they were smokers for their whole lives, right? We don't not give people treatment for liver disease that's related to alcohol use. There are all of these other disease processes that we treat seriously, despite there being maybe something that can be optimized from a lifestyle standpoint. And so even in the setting of unhealthful behaviors and obviously societal factors, obesity still is a disease no matter what. Weight stigmatization. So just briefly touching on this because I think it does affect our treatment of the disease. Commonly held beliefs that people with obesity are personally to blame for their weight, lazy, unmotivated, lacking willpower and self-discipline, and that they're non-compliant with treatment. Of course, media largely contributes to these ideas and the maintenance of these kind of anti-fat ideas. And then, of course, the discourse in the media when reporting on obesity does tend to stir up this moral panic to induce sort of an emotional response to people who are hearing, discourse around obesity. I won't kind of read these. I just wanted to have these definitions laid out. But I do want to highlight down at the bottom, internalized weight bias. That is actually when a person applies negative weight stereotypes or biases to themselves, and they engage in self-devaluation. This is something that is I see every single day when we're trying to treat this disease. It's people feeling like failures. I've dieted done every diet under the sun. I've never been able to sustain weight loss, and sort of devaluing themselves without understanding the chronicity and the complexity and the biology of the disease process and why they have regained weight over time every time they've been trying. So that internalized weight bias is really something that I see active in clinical practice every single day. Of course, that is also a result of some of the weight stigma and weight bias that these patients encounter every day related to their size. So why should we care? Obesity is the most stigmatized chronic disease. As many as 40% of adults with obesity report experiencing weight stigma or discrimination. Of course, the rate increases as BMI increases because obesity is visible. So you can't hide your weight, right? And so certainly in folks who are seeking out obesity care, they report very high rates of weight stigma and discrimination. Of course, this is encountered everywhere. Certainly, we have studies that look at healthcare, the workplace, hiring practices, education, acceptance into higher level education, things like that. And importantly, weight stigmatization has been associated with increased depression, diminished quality of life, decreased likelihood of seeking care, and then decreased likelihood of doing the things we know also help with weight loss. So some of the lifestyle changes we'll talk about. And again, from a medical standpoint, we know that these stigmas are associated with higher morbidity and all-cause mortality in our patients. Again, just to kind of hit this home, especially in healthcare, prevalent and pervasive weight bias and weight stigma. Of course, this disproportionately affects our female patients, our Black, Indigenous, people of color, and gender diverse individuals. Transitioning now just to talk about anti-obesity medicines and indications. So broadly, when we're speaking about any medicine, including GLP-1s for weight loss, these are the criteria that we have FDA approval for. So patients who have a body mass index of greater or equal to 30 without any other health problems are eligible for anti-obesity medication, or patients who have a BMI of greater than 27 who also have another comorbid condition such as high blood pressure, diabetes, sleep apnea are probably the most common. All of these medications are indicated as an adjunct to lifestyle therapy, which of course we think of as diet and exercise and behavioral modification. These are some of our endocrinology sort of guidelines, our ACE guidelines for lifestyle therapy. I won't belabor this, but it's here if anyone wants to reference what we typically would say kind of standard of care lifestyle therapy looks like. Treatment goals, according to the FDA for anti-obesity medicines, state that an effective anti-obesity medicine should result in at least a 5% weight loss, which indicates a statistically significant effect compared to placebo. We should have at least 35% of those patients achieving that 5% or greater weight loss after 1 year. And then typically in all of these trials, we measure things like systolic, diastolic blood pressure, waist circumference, lipid levels as well. So we can also say that these things help improve those cardiometabolic parameters. Our treatment goals when using weight loss medications or anti-obesity medications, we want to treat disease, right? We want to facilitate management of eating behavior and appetite, slow the progression of weight gain or weight regain after weight loss, and ultimately, we want to improve our health, quality of life, and then reduce body weight for our patients who struggle with overweight or obesity. Importantly, 5 to 10% weight loss has been shown to improve both kind of sick fat disease or what we consider metabolic syndrome related disease, prediabetes, fatty liver, things like that, and fat mass disease. I didn't belabor this, but those are things like sleep apnea, acid reflux related to the actual weight and pressure that obesity can kind of generate on the body. So that 5 to 10% weight loss is a critical number to remember because that's what we've always historically used as sort of reference for our outcomes for our patients. So types of anti-obesity medicines, we have short-term treatments and long-term treatments. Again, our short-term treatments historically have been used. You'll hear patients say, I just need a jump start. If somebody could just help me here a little bit, I know I can do it once I start to see some progress, right? And that's how they've often been prescribed, right? If we hear of medicines like phentermine, we only ever have had 12 weeks of data for phentermine prescribing. So oftentimes people will say, yeah, the medicine was working great when I was on it. And then I was on it for the 3 months and they took me off of it and I gained all my weight back, right? So short-term treatments don't really address the chronicity of this disease process. Of course, our longer-term treatments, of which GLP-1s fall right into that long-term treatment arm, are approved not only for weight loss, but also for maintenance of weight loss. And again, these medications tend to target the hormonal and appetite changes that accompany weight loss. Why, and just again, this is such a large topic, I could talk for days about any of these things, but when people lose weight, their brain is almost immediately starting to fight them, okay? So anytime the hypothalamus in our brain senses a reduction in calories, or we start to burn fat stores, our brain kind of goes into panic mode, okay? And our job is to not starve to death. We've evolved over hundreds and thousands of years not to starve to death. So when somebody is losing weight, almost immediately we see changes in their appetite hormones. Notably, their hunger hormone goes up, their fullness hormones go down, and their metabolism starts to decrease over time. We call all of those things kind of metabolic adaptations to weight loss. That's why about 90% of people who lose significant weight are going to regain it at 5 years, okay? So there is a biology to the weight regain. And these longer term treatments are geared at helping to mitigate the effects of that metabolic adaptation. So they are critically important for that chronic element of management. Of course, these medicines are all newer, right? Obesity has only been a disease or, classified as a disease for a little over a decade. We don't have 30 or 40 or 50 year safety data on any of these medications, right? So limited long-term safety data. So now I'll go into some more specifics about GLP-1 receptor agonists specifically. I will kind of touch on each of these. I probably, unless I have any prescribers on the call, I probably won't spend too much time talking about contraindications and things like that. I just like you to be aware of what GLP-1s we have access to and we prescribe, and a little bit of background about maybe why we would choose one over the other. So liraglutide is also called Saxenda as a brand name medication. This was our first GLP-1 for weight loss that was FDA approved 10 years ago at this point. This medication is also indicated at a different dosing tier as Victoza for diabetes. Again, it's a GLP-1, which stands for glucagon-like peptide 1 receptor agonist. The mechanism of action of these medications is that they increase glucose-dependent insulin secretion, decrease inappropriate glucagon secretion, and then also increases beta cell growth and replication. We see some slowed gastric emptying, preservation of a fullness or satiety feeling, which ultimately will decrease food intake and help to regulate appetite. Side effects, again, you'll hear me say this over and over again with GLP-1s. Most common are GI related and dose dependent. So we see nausea, we see diarrhea, constipation, vomiting, sometimes just kind of upset stomach, acid reflux, fatigue, and then we also watch for heart rate increases with these medications. They are contraindicated in patients who have a personal or family history of medullary thyroid cancer or a very rare genetic condition called multiple endocrine neoplasia syndrome type 2. The reason for this is in rodents, we do see a treatment-dependent, duration-dependent risk of a very rare type of thyroid cell tumor. We don't, again, know what to make of that as far as human risk goes, so that's why this contraindication is here. Medullary thyroid cancer is the rarest form of thyroid cancer in humans, but we do caution patients, of course, on any kind of new symptoms that would develop kind of in their anterior neck, difficulty swallowing, hoarseness, and then certainly we ask about family history as well. So that's a little bit about liraglutide. We don't use it a lot, honestly, anymore, because we also have trials that show that this next medicine here called semaglutide is superior to liraglutide. And it is, instead of daily dosing, semaglutide is dosed weekly. So this was kind of a hallmark, or kind of I remember when this study landed in the New England Journal based on the Wegovy trials, the STEP trials. So I just have a little graph here that shows once weekly semaglutide in adults with overweight or obesity. So the mean weight loss in this trial showed that semaglutide over the course of 68 weeks led to a mean weight reduction of 15% weight loss, a difference versus placebo. Again, both of these arms were receiving lifestyle changes as well, which is pretty standard for all of our weight loss medication trials, but a difference of 12.5% body weight between treatment and placebo arm. just to give you a little bit of background, because this, you might not kind of have any frame of reference for this unless you're using medications. Historically, our oral weight loss medications like Qsymia, Contrave, those are kind of the main ones. Obviously, phentermine, we don't have long-term data for, but really you're seeing on average anywhere between really probably 5 and 7% weight loss. Some of the Qsymia trials at high doses were showing us consistently 10% body weight loss. But then here we have this molecule that is injected once a week. Our average weight loss is 15%, which is, again, pretty marked compared to what we were seeing with older anti-obesity medications. Here's even more just broken down by percent weight loss here on the x-axis. You can see, 86% of patients on semaglutide lost greater than that clinically significant 5% weight loss, but almost a third of those patients also lost over 20% of their body weight. When we talk about obesity and the disease processes that are associated with obesity, we know the more weight loss we can achieve, the better people's health is going to be, reductions in blood pressure, blood sugars, fatty liver improvements, acid reflux. I mean, you name it, everything gets better. And the more weight we can lose, the more of those disease processes can either resolve or be better controlled. And this, of course, doesn't really even take into consideration quality of life implications for patients. So very, very staggering when we first saw these STEP trial published. So again, just touching on semaglutide, the brand name of this drug is called Wegovy, was FDA approved in 2021. This is also FDA approved for diabetes as Ozempic, and also Rybelsus, which is an oral form of the drug. Importantly, I think Wegovy is also approved for pediatric patients. It is the only medicine carrying that FDA approval for weight loss in 12 to obviously 17-year-olds. It is also newly approved based on the SELECT trial for secondary cardiac risk reduction in patients who have established cardiac disease. So prior stroke, prior coronary disease, or peripheral arterial disease. For again, an older kind of sicker cohort. But this was really critical because when we can show improvements in cardiac outcomes, that's when we can get insurance to start paying attention. So again, we'll talk a little bit about challenges to coverage with these medicines. Oftentimes we have to frame it in how are other disease states improving, because obesity is historically not alone enough to warrant coverage for these medicines in the eyes of insurers. But if we can say, look, we can show absolute risk reduction for coronary events, it's kind of a game changer. So important indications there. Again, similar mechanism of action that I won't kind of belabor. It is a subcutaneous injection given once a week. You can see the dose escalation laid out there. Typical side effects, you'll hear me say over and over again, nausea, diarrhea, vomiting, constipation, by far the most common. Typically, we see that when we start therapy and then sometimes when we're increasing the doses. For most people, we can manage these and we tell people what to expect. Where I think people get into trouble is when they're given, 5 doses of the drug and not given any kind of knowledge about the effects and what to watch for and how to hydrate and things like that. Similar contraindications, and then typically, again, we avoid using these in folks who have a history of pancreatitis. These were not studied in people who had a history of pancreatitis, and you can see some other precautions there that are probably just more relevant clinically. Moving on to tirzepatide. This was, again, another kind of huge drug in our little world of obesity medicine. So this kind of, I tried to get as many little graphs here. I'm sorry they're so small, but this looks at the SURMOUNT-1 data for tirzepatide for the treatment of obesity. So you can see this study was done over the course of 72 weeks. And you can see, again, this was also done at different doses of the drug, which was kind of unique to this study. So we can see doses of 5, 10, and 15 milligrams of this specific drug compared to placebo. And you see on the max dose of tirzepatide, patients lost about 21% of their body weight compared to just 3% of their body weight on placebo. Again, that middle graph there, patients who were losing at least 5% of their body weight. Remember, that's how all weight loss trials are kind of designed to prove, because that's where we start to see clinical improvements in obesity, statistics, or if you will, metabolic parameters. You see on that max dose tirzepatide, 91% of patients lost 5% of their body weight. Very marked in our world. And then, of course, you'll see the rates of nausea and diarrhea and constipation, which were the most common side effects. And then I have a little kind of remember the average placebo-adjusted weight reductions for our older, typically oral anti-obesity medicine here range between about 3 and 8.5 to 9% weight loss. So in comparison, all of a sudden to see a drug that can achieve 21% weight loss, which historically has only been achieved with surgical tools for weight loss, was very remarkable. So tirzepatide, the brand name of this drug is Zepbound. It was FDA approved in 2023, manufactured by Lilly. It is also indicated for diabetes as Mounjaro. This mechanism is novel. It's a GLP-1 receptor agonist, but it's also combined with something called GIP, which stands for glucose-dependent insulinotropic polypeptide, quite a mouthful. And dosing, again, is once weekly. There are 5 doses of this medication that we up titrate, and then 3 doses that are indicated for weight maintenance based on that trial I showed you on the last slide, because we do have data for both the 5, 10, and 15 milligram doses, so we can maintain patients at any of those 3 doses. Again, mechanism of action here, you can see increases the kind of insulin secretion, decreases inappropriate glucagon secretion, and also slows gastric emptying. Side effects, can read them again, but typically very similar to our other medications, and then same contraindications with the medullary thyroid cancer. So some limitations to, prescribing these medicines, I would say, in just big picture obesity care, is practitioner discomfort with long-term use of anti-obesity medicines. When we think about education of obesity as a chronic disease, I graduated from medical school in 2013. I think I probably got 2 nutrition lectures in my first year of biochemistry, and that was it. And then from there on, and clinical rotations and things like that, we hear we're told to tell our patients, yeah, lose weight and this will get better. You should work on weight loss. But never did I encounter practical advice for how to lose weight until I lucked into a rotation in obesity medicine during residency, which I feel very lucky to have found, because I didn't even know it was a field of study, much less that there were things that we could do to help people with weight management. So again, that speaks to, if our healthcare providers don't know how to treat obesity, aren't aware of perhaps their own internalized weight bias or weight stigma, how can we expect our patients to understand their obesity and not be blaming themselves over and over again, which just makes everything harder to treat, harder to manage. So on some level, fundamentally, it's a lack of knowledge, lack of understanding about the biology and all the complexities of the disease state. Of course, cost and lack of insurance, which I'm sure we will get to. These medications are new, they are expensive, there is very little coverage without somebody having a diabetes diagnosis. Again, we will cover medicines when people get sick. We will cover people's cancer treatment. We will cover diabetes treatment. We will cover heart failure exacerbation admissions over and over again. But when we look at coverage for preventing disease in this country, unfortunately, it's very minimal. Hopefully we can advocate and continue to keep growing and increasing. And when we have more and more effective tools and we have more research, my hope is we're sort of on just the starting point of hopefully where we can go with helping to manage this chronic disease. I will say, once anti-obesity therapy is initiated with an anti-obesity medicine that does not have a limitation for use, the decision to continue or discontinue that treatment is based on the individual's clinical response and the practitioner's kind of judgment regarding, what's the risk of weight regain coming off the medication, how much, that's I think a very nuanced conversation based on the patient. Again, a lot of patients I see, especially with GLP-1 medicines, are saying, okay, so how long do I have to stay on this, right? I only want to be on it for 6 months. And so we have some trials that show with discontinuation, we start to see pretty rapid weight regain, right? Because again, the biology of weight regain is still very much there. We're taking away a tool that was effective at managing the chronic disease. We can't be surprised when the chronic disease recurs, right? But because people think they should be able to manage their weight themselves and do the right things and what have you, there's still that that perception of I only want to be on this temporarily. I find that if I can frame this in a conversation of kind of being a minimalist and saying, hey, if I can get your weight down 15%, I can get you off of your blood pressure medicine. I can get you off your metformin for your prediabetes. I can get you off your acid reflux medicine. You know, we can manage a lot of other chronic conditions if we're managing weight well. A lot of times that's a little bit kind of easier to swallow than adding another medicine for another disease process, but I think it's very much dependent on the patient. So just briefly touching on advocating for coverage. So again, health systems and administrators are not immune to weight biases in their approach to their pharmacy policies. Unfortunately, the willpower, just try harder, still really hits our AOM policies. Again, general lack of understanding and acceptance of obesity as a disease. I still hear it all the time with people saying, oh, that patient just doesn't want to try, or that sort of thing. Doesn't help that there are no accepted best practices. Every other, health networks are looking at what other networks are doing and saying, oh, that group got rid of their policy, we should get rid of ours. Or, this network has coverage and is using it as a recruitment tool, so maybe we should do that too. So there's really no standardization as far as coverage for these drugs. It's still very much in flux and varies with, frankly, every employer. So as far as it affects our clinic, we really have to say this is still considered specialty medication. It's all up to you, your employer, whether they're opting into covering these medications or opting out. Again, it is difficult to make return on investment arguments when we have newer drugs with limited long-term data. So again, insurance is more likely to pay for bariatric surgery because we've been doing that longer. And we do have better, harder data that we can say, improvements in mortality, reductions in cancer risk, reductions in cardiovascular disease risk. We have all that data because we've been doing bariatric surgery for longer. We're just going to need to keep kind of compiling data and getting people to stay on these medications chronically to then be able to say, hey, your investment in preventive measures is paying off, right? So that's still a little bit difficult. And then I mentioned kind of needing to reframe the conversation to outcomes that matter maybe more to other administrators. And again, this was important with the SELECT trial I mentioned with the improvement in the cardiovascular outcomes with Wegovy or semaglutide. Again, Medicare for the first time ever covered an anti-obesity medication in that specific patient population. So again, patients who have had cardiovascular events, strokes, or history of peripheral arterial disease, they were greater than 45 and they have obesity or overweight, Medicare is now paying for Wegovy for them. So that was really critical. That's why we still really need to often kind of study other disease processes that are getting better along with obviously seeing weight loss. Just personally, I will say obstacles to, I think, our care of obesity big picture, lack of affordable and accessible mental health resources. There's a very strong bidirectional relationship of depression and obesity. Typically, as one worsens, the other worsens. And we have our clinic is a comprehensive bariatric practice with surgeons. And then I see medical weight loss patients. I have a full-time nurse practitioner seeing medical weight loss patients. We've got dietitians, we've got a psychologist, but our psychologist right now only does pre-surgical evaluations, basically looking for big red flags that would prevent someone from doing okay with a bariatric surgery. We really don't have anybody for our medical weight loss population specifically to talk about, obviously, their relationship with food, their self-esteem, their depression. So many things influence people's eating behaviors. I see a very high rate of disordered eating that really isn't addressed by medications or surgery. And it's very much a bigger problem, right? And sometimes people eat because they're depressed. So we have to optimize their depression before we're going to be able to see meaningful improvements in their weight. So, there are some other factors here. We know even folks who have had bariatric surgery, they tend, once they're 2 years out from surgery, we start to see some weight regain. Not always, but sometimes, right? And so there's also a push to be using medications in our post-bariatric surgery patients, because again, we know just because they had surgery doesn't mean that their body's not going to be fighting them longer term to regain that weight back. So in my perfect world, every patient entering a bariatric practice would have a psychologic evaluation and regular follow-up, kind of helping with trauma, strengthening non-food coping skills, addressing ambivalence to change, and then ultimately supporting their habits that are going to be really important long-term for their weight loss, and then also to prevent and mitigate weight regain. So the future of anti-obesity medications, currently we're mainly focused on combining GLP-1 receptor agonists to other drugs to kind of really, again, like the tirzepatide added another receptor to it. The one that you may have heard of that's in phase 2 trials right now is called retatrutide or retatrutide. I'm not pronouncing it correctly. That actually has 3 receptor agonists, and the weight loss has been even greater. So really looking again at the hormonal effects and the kind of the fullness hormones, that seems to be really where the research is right now. There's also interest in what type of weight patients lose, right? Can we lose fat mass greater than lean mass? Because obviously we want to keep muscle mass around, that's important for your bone health to have good lean muscle mass retention. So there's some biologic agents that are looked at right now to see if they can preferentially preserve lean mass while still losing fat mass. And then you can see setmelanotide is a good example of an FDA-approved medication that targets actually genetic causes of obesity. We know obesity is associated with at least 100 genes at this point, likely a lot more. And it's kind of a polygenic inheritance. So again, how those genes interact in different patients in different environments is very interesting. But I think at some point we are going to be able to genotype patients and be able to really target therapy for their kind of type of obesity. So just a little background about my practice. I did start my medical weight loss practice right out of residency in 2016. At that point in time, we were using a lot of meal replacement products, putting people on kind of liquid, very low calorie diets. Hardly ever used medication, perhaps just in the setting of people who were safe and appropriate for phentermine, and using it again for a short time. I had a ton of patient turnover, limited long-term successes. People were afraid to start eating real food for fear of weight regain. So it was very, not looking back, probably the best approach, but that's kind of how we practiced obesity medicine. Of course, then COVID happened. We had broader access to telehealth. People were experiencing more food insecurity at that time. So our patients certainly weren't using as many meal replacements. Again, we saw worsening of, I think, reliance on food and alcohol to help cope with kind of that stress. Now, since I would say probably 2020, 2021, I certainly am more aggressive about screening for eating disorders and kind of what I am recommending as far as nutritional guidance for patients. We're definitely shying away from meal replacements, focusing more on healthful eating, real food, whole food eating. And then I never delay treatment with anti-obesity medication when people obviously meet criteria for medicines. And again, every patient that I'm seeing in bariatric practice has tried yada, yada, yada. I can name all the things that they've tried. So I know that they're appropriate, in addition to the lifestyle piece, to start medication. I also tell them about the kind of longevity of this disease process, how nothing that we're going to do is just make this disease go away, and sort of my philosophy on, again, utilizing medications long-term for long-term success. At this point, pretty much all of my patients lose over 10% of their body weight, probably closer to 14, 15% of their body weight, and they enter a weight maintenance phase with us, which means they are our patients forever, and we have very little turnover, and my practice is busting at the seams, and all I do is ask for more help and more people doing what I do. So it is a very quick turnover just in terms of even my career, which has been only about 8 years, just to see how things have shifted so dramatically. And I think a lot of that is to do with the GLP-1s. So a summary, obesity is a chronic, relapsing, lifelong disease that requires comprehensive care, including lifestyle changes, pharmacotherapy, sometimes bariatric surgery, and then consistent follow-up. I'd like us to be able to understand the real-life implications of weight bias and stigma affecting patients living with obesity. And then, of course, knowledge is power. When you know better, do better. Advocate for your patients with obesity. Think about what kinds of chairs you have in your waiting room, how big your blood pressure cuffs are, making people feel just better in a clinical setting when you're dealing with a population battling obesity. And then, of course, consider use of longer-term anti-obesity medicines, such as GLP-1 receptor agonists, to help people not only lose, but importantly, sustain meaningful weight loss. And then buckle up because it's an exciting time for obesity pharmacotherapy. I'm sure if I gave this presentation in a year, we'd probably have 1 or 2 other drugs that we're talking about. But it's certainly a very exciting time for science and for our patients and how hopeful they feel. I always end with this slide because I like you to have a resource to test your own implicit bias. This is a website on Harvard's system where there's a bunch of different disease states that you can actually test your own implicit bias as it pertains to obesity. So I always encourage that. I think it can be very enlightening, even if we think we're pretty weight inclusive. And it took me probably a couple years to actually come out kind of net even. So whether we wanted to or not, obviously most of us are not people with bad intentions, but we are, again, all growing up in the same kind of culture and society, and that affects how we view things. So I encourage you to test your implicit bias. And then I have a couple slides for references, and now I am certainly happy to take questions and hope I didn't take too much time. Oh, I kind of did.
No, that's perfect. Thank you so much, Dr. Whitney. That was a very, very insightful presentation. Thanks for sharing your expertise. I didn't have any questions in my chat, so I can go ahead and open. If you guys have any questions, you can just get off of mute and ask the questions.
Whitney, could you just email me that test link so that we can email it out to the coalition after?
Yep, for sure.
Okay, thank you.
Hi, my name is Tracy Akers, and I'm an RN. So I loved your presentation because I can follow it. But my question is, a lot of times I'm seeing or hearing from friends and family and colleagues that if they've been prescribed the medication for some kind of chronic condition, they lose the weight, like especially like type 2 diabetes. Now they're weight loss, and now they're not even showing that they're diabetic anymore because their A1Cs are in normal range. Now their insurance companies won't cover it.
Yeah.
So are you seeing that, or we're finding out that even if they do have comorbidities, insurance companies aren't covering it?
Yeah. So that's honestly probably one of the most devastating things that I deal with is both patients who are getting perhaps a Wegovy or a Zepbound covered for obesity, and then maybe the next year their employer has taken away coverage, right? So they can't afford the medications out of pocket. And we know to expect weight regain in those circumstances, but mentally that's even if we switch them to our best oral combination and they tolerate that well, it's still not going to get them close to the results of those GLP-1 medications. And so that is obviously devastating for patients alike who have been doing very well on these medicines to be seeing their weight kind of trend back up. I think we do our best to kind of mitigate that when it happens, but unfortunately with the cost of these drugs, there's not a lot of other great options. Certainly some people go to compounding pharmacies. I myself do not prescribe these medications to compounding pharmacies. I think people have to I understand the desire to switch over to something that might be more within a budget. But we also don't know what patients are getting. And there have been reports of, people getting just sugar alcohol that they're injecting. I personally have patients who go sometimes from a brand name to a compounding drug, and they're like, I notice a little something, but nothing close to what I was on when I was on the brand name medicine. As far as the diabetes piece, I typically will still try to always use the diabetes diagnosis because, again, they can have diabetes and then have very well controlled diabetes. And so while we like people to be able to say their diabetes is cured, I would argue, again, that therapy was helping to treat and manage their diabetes. So I would still be using that diagnosis code for the prior authorization renewals, even if their A1C was normal. At one point, they did meet criteria for diabetes. So on those prior authorizations to get the drug, I would still be using that. Now, I have had some insurance companies who say, we're changing our policy, and unless your A1C is over 7 and is uncontrolled, we're not going to cover GLP-1s. I think that's wild because they definitely are just pushing back on how sick someone has to be before they're going to treat them, even though clinically they meet criteria for that disease state. So that always is baffling to me, but obviously the cost of these drugs is a huge issue. And I obviously understand it's not as simple as I would like it to be, where we just invest in people's health and preventive medicine and that sort of thing, that would be great, right? That's not how our system is set up in this country at this point. So, yeah, I think, I don't remember exactly what your question was, but clinically, I would still be trying to use the diabetes diagnosis for that specific population, even if their A1C was normal. At some point, they still did have diabetes. They did meet criteria for that medication. And so while the patient probably wants it off of their my chart or their problem list, I would say, hey, we kind of need to keep this on so we can keep you on your medicine. And usually that's a good enough answer because they want to stay on their medicine.
Thank you.
Sure.
What are you hearing about access to the medication with the shortages? Has that started to be better, or is that still a challenge?
Yeah, I would say, great question. Still a challenge, but definitely better. So Wegovy, really since it came out in 2021, every year has gone through some degree of supply chain shortage where even when the drug's covered, we can't find it. Most recently, it was last June up until about May of this year. But since May, I have been able to see Wegovy pretty much readily available. Obviously, for the Lilly drug Zepbound, it was just FDA approved last November, and they kind of say, hey, we expect the drug companies are always very much, we expect demand to exceed supply for the foreseeable future, yada, yada. Obviously, they're trying to make their new production plant up in Lebanon and are investing in this drug because now, we're going to have data for sleep apnea and other things coming down the pike. The demand is going to be so high for that drug. But generally, it's, kind of depends on where the patient lives, which pharmacy they're using. They definitely do have to do a little bit more calling around for specific doses. So sometimes, if I want to up titrate someone, I might have to keep them on the same dose for a month longer to allow the pharmacy to order the next dose. So it's by no means perfect, but I would say it's better, certainly this summer than we were last summer.
Great. I don't think there's, I didn't ask Dr. Blakely, could we have a copy of those slides?
Sure. Yep. I'm
Okay.
happy to email that to you.
Great. Okay. Well, thank you. If we have any other questions, let me give it a couple minutes.
Keep going on and off. So yeah, the article basically said that they're doing a lot of the drug trials they do on people, especially older persons. It's mostly on men, and so women are not equally represented in those trials, and so they don't always get the information about the effects of the medications for females. And I don't know what can be done about that, but I found that to be an interesting observation that the same medication that might be very effective for a 65-year-old man may not have the same outcome as a 65-year-old woman. And I don't know, Dr. Blakely, whether you have any comment about that. And again, I don't know what can be done about it other than just be aware.
Yeah, I think it's always really important when you're looking at trials. I'm honestly, even in obesity studies, the vast majority of folks historically who are in our anti-obesity medication trials are middle-aged white women. They're doing a more, I think, dedicated recruitment process to try to get more diverse populations and age groups and things like that. But most of our anti-obesity trials experience sort of the same thing. So are more skewed to female patients, specifically white women, with the exception of the SELECT trial for the cardiovascular data. That was mostly men. Obviously, it was an older cohort, people with established cardiovascular disease. And so that was more likely to skew male. But yeah, I think when you're talking about an elderly population specifically, you need to be thinking about, obviously, women and men age differently, and there's menopause and all these other considerations for female patients compared to male patients. So just my thoughts. Yeah, we have to always take into consideration kind of what the study population looks like.
And so why would there have been more women in the, I mean, I think I know the answer, but I'll rely on your answer.
Yeah. Women are just more likely to seek obesity care, right? Women have to have periods and have babies and go through menopause. They're shorter, right? I mean, there's all these factors that go into play as far as BMIs and just frankly, we know women are more likely to seek out, medical help if needed. And so that's generally, again, the people who were enrolling in the trials tended toward middle-aged, more white women.
So Jessica, that's really all I had to say about it. I just wanted to bring it to people's attention because I was not aware of that. And so when I read the article, I thought, well, that's something we should probably at least know about.
Yeah, I agree. I think Lisa and I went to the Indiana Cancer Consortium, and they did talk about how they're trying to diversify their cancer trials when it comes to treating cancer. So it was really interesting to see that they're really trying to push for it, but they're just not getting, as diverse. But hopefully we'll see better in the future. Yes, Lisa.
Yeah, I was just going to say, some populations also are reluctant to engage in trials based on, things that have happened in the past. And so I think some of that education for specifically, members of the African American community. And so I think a lot of education, even myself, when I read, the things about trials, I always kind of question myself as to, oh, what does that mean if I would get the placebo? Or, so I think it's a complex issue. And I know I've seen a lot more, I guess, advertising or marketing of studies to different populations than what I used to see in the past. I mean, I just see it regularly on Facebook now, and in the past, I'm not sure how they actually marketed studies. So,
All right. Well, thank you so much, Dr. Blakely, and thank you everyone for attending and asking some wonderful questions. And we will see you next month.
Thanks for having me.
Thank you.
Have a good day, everyone.
Yes.
Thank you.
Thank you.